Hello. Hi.
Hi again.
Hi. Hello, I'm Heemanshu Dave. I'll be taking your orthodontic lecture. Good afternoon, I'm Dr. Heemanshu. I'll be taking your orthodontic lecture today. I hope your paper was nice. I hope you can hear me. Yeah. So we move on to the ortho paper, in which the first question says that if the interincisal angle is 131 degrees, it implicates what? Now first let us see what is interincisal angle. It is the angle made by the long axis of the upper central incisor and the lower central incisor. Now normally the interincisal angle is supposed to be 135 degrees. But since this is less than 135 degrees, it means that it is acute. Acute angle indicates that teeth are proclined. When the teeth are proclined, the angle becomes acute. When the teeth are retroclined, the angle becomes obtuse. So the answer will be, there's one doubt in this question, that if you consider the normal, the range, then the interincisal angle would come out to be normal, not proclined. But then since we don't have that option, we have to understand what the examiner is wanting to ask us. So in that case, he has taken the mean as the average, and if it is less than mean, it is proclined, and if it is more than mean, it is retroclined. We move on to the next question, which, before moving on to the next question, let us understand the concept of cephalometrics. One of the very frequently asked question in cephalometric is about cephalostat. What is the distance between X-ray source and the mid-sagittal plane of the patient? It is 5 feet or 60 inch. Now, if the question is framed like this, that the 5 feet distance in a cephalostat is the distance between X-ray source and the patient, then read the next option. Try to find out mid-sagittal plane. Because if you mark distance from X-ray source and the head, then it is lesser. So it is always the distance between mid-sagittal plane and the X-ray source, which is 5 feet. If the question is the distance between X-ray source and the X-ray film, then it becomes 1 or 1.5 feet more. 6 feet or 6.5 feet. Next, let us see some anatomical landmarks which are important with respect to our MCQ exams. Nasion, we all know, it is the intersection of frontal bone and the nasal bone at the frontonasal suture. It is a unilateral landmark seen on cephalogram. Then we have anterior nasal spine, most anterior point on the bony hard palate. We have A point, the intersection of alveolar process and the basal bone of maxilla. B point, intersection of alveolar process and the basal bone of mandible. Pogonion is the most anterior point on the bony chin. Gnathion, anterior inferior point on the bony chin. Menton is the most inferior point on the bony chin. Out of these points, Gnathion is a constructed point. That is, you have to see a distance from Pogonion to Menton, and the center of that distance is supposed to be Gnathion, or you have to mark a perpendicular from Pogonion and a perpendicular from Menton. The intersection is Gnathion. Gonion is the most posterior inferior point on the inferior border of the mandible. Articulae is an important point. It is asked in some MCQ exams. It is the intersection of posterior border of the ramus and the inferior border of the base of the skull. Dasion is the most anterior point on the foramen magnum. Cogonion, the most posterior and superior point on the external-auditory meatus. Condylion, most superior point on the condyle. Orbital, the lowest point on the orbital rim. PTM, I'll be answering to that later because there is an MCQ in this exam on PTM. There's another point which is Bolton's point, AIPG and AIM's favorite point, I would say, because it has been asked in many exams. Bolton's point is the most posterior point on the postcondylar notch of the occipital bone. Next is a point whose position would not change or would change with orthodontics. That is point A. Generally, point A has been asked as a point whose position would change with orthodontics, like when you retract the teeth, retract the upper incisors, point A also moves behind. If you procline the teeth, the point A moves behind. Also, let us also understand that there are certain planes which are used in orthodontics. Out of that, ascent plane is the most stable plane. It does not change after 9 years of age when the base of the cranium is fully grown. There's another important point called as xi point. Now this is a constructed point and it is considered as geometric center of mandible. How it is drawn? There are certain R1, R2, R3 and R4 points which are marked on the mandible. There's one point which they mark on the anterior border of the coronary process, the deepest point. Anterior border of the ramus on the coronary process, the deepest point. The point opposite to that is also marked. Then R3 is the point, lowest point on the sigmoid notch, and a point opposite to that on the inferior border of the mandible. All these 4 points are joined by lines which form a rectangle. Now this rectangle, they construct 2 diagonals from the diagonal points. When you get the center of this, it is called as xi point. It is considered to be geometric center of the mandible. We move on to the next question. In cephalometric analysis, the y-axis is formed by the angle formed by the plane joining cella to gnathion and the FH plane, the angle formed by the plane joining nasion to gnathion and the FH plane, the angle formed by the mandibular. No, it is not mandibular plane or IMPA. It is related to cella, gnathion and FH plane. So the answer is A. Now what y-axis indicates? Y-axis indicates the vertical growth of the nasomandibular complex, nasomaxillary complex and the mandible. If the patient has a vertical growth pattern, the y-axis is increased. If the patient has short face or horizontal growth pattern, the y-axis angle is decreased. We move on to the next question, which is Dontrix gauge is used for. In orthodontics, we use many accessories like the active components, springs, elastics, elastomeric chains. These, they have forces when we apply on the passive components. So you have to measure so as to give the optimum force to the teeth. If it is exceeding optimum force, the treatment or the movement will be delayed. Hence, always you have to use certain gauge to measure the force and then put this active components onto the passive components. For measuring that force, a very common instrument in orthodontics is a Dontrix gauge. So Dontrix gauge is used for measuring force. It is something like this. This end has a hook which can be used. Okay. Now there is a request to repeat the cephalostat. Now this is the cephalostat. We have the X-ray source, we have the patient in head positioning device which goes into the ears of the patient. At the same time, the X-ray film for the lateral cephalogram is placed at a distance of 15 inch from the patient. The distance from the X-ray source to the mid-sagittal plane of the head of the patient is 60 inch, which comes out to be 12 inch is 1 feet, so 5 feet. So distance from X-ray source to the mid-sagittal plane is 5 feet, and the distance from X-ray source to the X-ray film will be 15 inch more, so it will come out to be 6 feet and 3 inch. So next we come on to certain points on the cephalograms. Again, there is a request to repeat these points, so I would go in brief about these points. Certain points on the cephalogram of patients are very important with regards to MCQ exams. Out of that, Bolton's point is the most prominent point on the post-condylar notch of the occipital condyles, of the occipital bone. Now, this point has been asked many times, that's why I am including this. Also, point A would change with the orthodontic treatment. For example, if you procline the teeth, the root is going to go inside. When you tip the teeth forward, tip the crown forward, so point A might go slightly behind along with the root. But if you protrude the teeth, like you move the tooth bodily out, point A is supposed to come out. At the same time, if you retract the teeth, point A would go inside. At 9 years of age, the brain is fully developed, so the cranium stops to develop. Hence, the ascent plane is considered to be most stable plane, which is at the base of the cranium. Other important points which are other than the usual points are articulae, which is the intersection of base of the cranium. This is the base of the cranium. Intersection of the base of the cranium and the posterior border of the mandible. You all know basion is the most anterior point on the center of foramen magnum. Center of the anterior margin of the foramen magnum. Out of these points, Matheon is a constructed point because we have to draw a perpendicular from Pogonion and Menton. The intersection of this forms Gnathion. Some authors also consider the midpoint from Pogonion to Menton as the Gnathion. But both ways, we have to first mark Pogonion and Menton and then we can find out Gnathion. Xi point is the geometric center of the mandible. It is used for superimpositions. But still it has been asked. Superimposition is a postgraduate topic, but still it has been asked, so I have included. There is a complaint that there is no audio and video. I hope I am audible. Everyone can hear me. So next, in cephalometric analysis, y-axis is formed by what? It is formed by the Sella-Gnathion plane and the FH plane. Y-axis is used in Downs analysis. Downs analysis is very important with respect to the MCQs asked, because not many MCQs are asked from Steiner's analysis or McNamara analysis, but a lot of MCQs are asked from Downs analysis just because it is very well taught in the graduate school. So y-axis is formed by what? It is formed by joining the Sella-Gnathion. Imagine if you join the FH plane from chorion to orbital and you join Sella-Gnathion. Now the angle which is formed between these two planes is represented by y-axis. This angle increases if the mandible goes down or the patient is vertical growing, and this angle would decrease if the mandible would go up, because the Sella-Gnathion line will be more acute as respect to the chorion orbital. It is seen, acute angles are seen in horizontal growers. Next, as I explained, Dontrix gauge is used to measure force. It has two ends. One end is like a hook, which when you engage a component, an active component like elastic, in a hook on the passive component like bracket, then you pull with this hook and the readings can be read here, which are marked, which will show how much pound of force or how much gram of force you are applying through that elastic. Also, there is another end which can be used in the same way. Here you have to pull. There are certain components which we have to push, and we find out the force. Now, this is also a popular question in normal edge and centroid relationship. Now first, let us understand what is edge and centroid. Johnson and Tully, they had, with respect to retention, given this concept of edge and centroid. What is edge? Edge is the incisal edge of the lower incisors. Centroid is the centroid or the geometric center of the upper central incisor. It can be only visualized in lateral cephalogram. Even when I was appearing my entrance exams, I could not understand this concept and I had almost by heart this question. But when I went through the orthodontics post-graduation, I came to know it's very simple. If you just visualize a cephalogram, the upper incisor and the lower incisor, the edge of the lower incisor is the edge in this question, and the centroid is the center of the upper central incisor. Now, normally, for the orthodontic treatment to be self-retentive, to be stable after the brackets or the braces are removed, the centroid has to be behind the edge by 1 millimeter, or the edge has to be in front of centroid by 1 millimeter. Edge is in front of the centroid by 1 millimeter. So it is with respect to this retention that this question has been asked. If the centroid is more than 1 millimeter behind the edge, then it is not stable. Or if the centroid is ahead of edge, then it is not stable. The position of lower incisor is very important with respect to the retention phase. Next, we come on to the fifth question. The facial profile of a patient in chronic mouth breathing is. Now, let us understand the pathophysiology of mouth breathing. What happens in mouth breathing is that the patient has to always keep his mouth open. The lips are open, at the same time the teeth are not in occlusion. So the usual side effect seen in this patient is that the posterior teeth, especially the maxillary posterior teeth and the maxillary bone, is overgrown because there is no contact. There is no opposing force of mandible on the posterior teeth of the maxilla, due to which the maxilla and the posterior maxillary teeth, they would come down, the mandible would slide open in clockwise direction, which would make the facial profile long, and at the same time, since the mandible rotates around the axis at the condyle, it moves in the clockwise direction and becomes more towards class 2 or convex facial profile. So, hence in chronic mouth breathing patients, the profile is long and convex. Let us find out what are the difference between the long face syndrome and the short face syndrome. Long face syndrome, they generally show open bite. As I told you, the posteriors, maxillary posteriors are extruded more, due to which mandible would open. There would be open bite at the anterior. Short face syndrome, as we have clockwise rotation of the mandible in long face, in short face we have anti-clockwise rotation of the mandible, due to which there is a deep bite. So much so that in class 2 due to sometimes we have lower incisors touching palatally on the upper incisor palatal gingiva. In long face syndrome, the centroid is the geometric center of the upper incisor. There is a doubt which has been asked. It is the center of the geometric center of the upper incisor. We did not go into detail just because we have to answer this question one day before. We cannot keep on by hearting such things. If we just have the concepts in our mind that what is centroid and what is the edge, then we would always say, yeah, edge has to be ahead because it touches the upper incisor edge. When the lower incisor edge is just touching the upper incisor, the centroid has to be behind. Now again, coming to the difference between long face and the short face. Long face is also called as hyperdivergent face. Why it would be called as hyperdivergent face? The concept behind this is that we have different planes in cephalometrics, like how I told you. There is SN plane right from the cranial-most position. We have SN plane, then we have FH plane, then we have the palatal plane on the maxilla, we have occlusal plane, and we have the mandibular plane. It has been seen in this long face or mouth breathing patients that all these planes, they diverge from each other, like right from the sella, Frankfurt, and the palatal plane. The other two planes, occlusal plane and the mandibular plane, they diverge. Hence, it is called as hyperdivergent. Normally, they would diverge slightly. How much? It would be as much as the angle between FH plane and the mandibular plane, which is 25 degrees, the mandibular plane angle. Now, if the angle is more than that, it is called as hyperdivergent. At the same time, in short face syndrome, these planes are hypodivergent. Now you would ask why they have called it hypodivergent, why not convergent? It is never convergent. They are hypodivergent, meaning from 25 degrees it is less than 25 degrees. That is 20 degrees, 19 degrees, might go up to maximum 14-15 degrees. So they are going towards parallel rather than converging. Hence it is called as hypodivergent face. Now, long face syndrome, they have maxillary alveolar hyperplasia. Like, since they are mouth breathers, they have open bite, they do not have contacts during growing age, the maxilla overgrows. In short face, there is no maxillary alveolar hyperplasia. There is maxillary vertical access. Frequently, these patients, they have a lot of gingival display, which is due to maxillary vertical access. In short face, the lips almost cover the upper incisors, so there is no vertical access. In fact, a little less visibility of upper incisors. Since they are retroclined at the same time, they are fully covered by the upper lip. There is anterior vertical excess of the lower face also. In long face, since the maxilla is overgrown in vertical direction, the ramus also grows along with that, because the condyle is a secondary cartilage. It responds to the pull. So ramus also grows along with that. And there is vertical excess of the lower face as well. Whereas in short face syndrome, there is anterior vertical deficiency, since the mandible is rotated anti-clockwise, upwards. Since mandible is rotated upwards, there is decrease in the lower face height, which is called as anterior vertical deficiency in short face. Now, as I told you, hyperdivergent is same as high angled face. The mandibular plane angle is increased, the angle between FH plane and the mandibular plane. In short face, the angle is decreased. Finally, the example of long face. It is mostly seen that such long face people, they have class 2 div1 malocclusion, and they are mouth breathers, adenoid faces. They are also called as adenoid faces. Short face syndrome, the example is class 2 div2. It is also called as German or Deckpiece bite malocclusion. Deep bite is also called as Deckpiece bite. But this can be an MCQ. Yeah, the concept was given by Johnson and Tulley, Tulley. The concept of edge and centroid was given by Johnson and Tulley. There was a doubt, so I answered that question. Now we move on to the next question, which says that the minimum incidence of cleft palate is seen in which of the following? As you all know, cleft palate is a congenital malformation. Let us see what is incidence. Incidence is the occurrence of the malformation in the number of live bird seen at the point, at one point. For cleft palate, the incidence in Caucasian is 1.6 per 1000 individuals. Like if you take 1000 individuals being born at this time, 1.6 birds will have cleft. In Afghans, it is the highest, about 4.9 individuals in 1000 live birds. In Negroes, it is lowest, 0.4 per 1000 live birds. But with respect to Negroes, we have one malocclusion which is more common, that is midline diastema. Midline diastema is more common in Negroes than any other population. In India, the incidence of cleft, by different studies, we have different pools of studies. If you calculate them together, we find that in India, like the South India, North India, and the Northeast, we have 1.2 cases in every 1000 individuals. Anywhere in the world, it has been reported the cleft incidence is from 1 in 600 to 1000. Now, in India, the cleft lip plus cleft palate, like a patient having cleft lip and a cleft palate, the incidence is 1.25, which shows that a cleft patient is more likely to have a cleft palate also. A lone cleft palate, the incidence is less, that is 0.46 per 1000 individuals. With respect to males or females, the incidence of cleft lip and palate is more in males, while the incidence of cleft palate is tremendously more for females. Research authors, they have tried to find out why is this, but There are still studies going on. There is no answer to this. But cleft palate is a lot more in females than in males. Now laterality. In unilateral clefts, left side is more frequently involved than right side. Like a patient when born with cleft, left side will be more common, then there are more chances of he might be having left-sided cleft than a right-sided cleft. Of all the anomalies we study, whether it's cleft palate or microcephaly, there are many congenital anomalies, encephaly. 1/3 of all these congenital anomalies are contributed by clefts. Now we come on to the question. The minimum incidence is seen in which of the following population? Negroes. Maximum incidence is seen in Afghans. Seventh question, which says that alizarin dye, it stains what? Alizarin dye was found by as a vital stain by Hunter. Now what we found when he was studying the bones of pigs in that area, he found out that pig bones were in a pattern stained by some dye. So he found out what they were feeding on. He found out that these pigs were feeding on the textile waste which contain alizarin dye. Now he came to know that when such dyes are injected or they go into the system, the systemic circulation, they would stain calcium in the bone. Hence, since then, alizarin dye has been used to study the growth pattern, because wherever the calcium is getting deposited, the new growth is taking place, it would get stained, which would help us to understand how the growth pattern is taking place, how much the growth is taking place, like what is the rate of the growth. Let us now go through study of growth. There are two main approaches with respect to study of growth. One is measurmental approach, the other is experimental approach. Measurmental approach is that you measure the distance. And the examples of measurmental approaches, first is craniometry, where you have the dead skull, dead tissues on which you measure the distance directly on the skull. The disadvantage of this is that you can have a cross-sectional study on this. Of course, you cannot have a longitudinal study on that skull. Next, we have anthropometry. The advantage of anthropometry is that you measure directly on the surface of the skin. The advantage is that we can do longitudinal study, which is a disadvantage for craniometry. But the disadvantage with this anthropometry is that we have to mark the points on the soft tissue, and then we predict the distance on the hard tissue. So it is a prediction. It is not the actual distance of the hard surface. Hence, there is a disadvantage with anthropometry. With regards to this disadvantage, they came up with cephalometry, in which there are live individuals and you take the X-ray, you get the hard tissues and mark the points and measure. So cephalometry is one of the best approaches to study growth. But in cephalometry, the best way to study growth is by using a serial cephalogram. Serial cephalogram is like a patient cephalogram is taken at this point, and then the same patient's cephalogram is taken after 6 months to find out what is the growth pattern, how is mandible maxilla growing, whether in vertical direction or in horizontal direction, whether they are going anti-clockwise or clockwise, or the rate of the growth in 6 months, how much the growth has taken place. Has at every 6 months the growth decreased or it has increased. So serial cephalogram is the best way to study growth. Later we came up with experimental approach to study growth, which used dyes. Different dyes have been used for this purpose, like alizarin, tetracycline. Then we have radioactive also, technetium 99. Such dyes can be used, can be injected. They would stain specifically to the growing bones where the calcium is being deposited, which can be read on the X-rays if it is radioactive, and we can find out how much the growth is taking place. Next, we move on to a dentist performed restorative procedure in an 11-year-old child and found that primary molars were in various stages of exfoliation with slight anterior crowding present. Now this question is a bit vague. A dentist has performed restorative procedure in an 11-year-old child and has found that primary molars were in various stages of exfoliation. This shows that there are some primary molars who are just about to exfoliate. There are some who would exfoliate after 6 months, some after 12 months, because it is 11 year. After about 1 year, you would expect all the primary molars to be exfoliated. But there are two problems. One is that the exfoliation is taking place. At the same time, there is a restorative procedure which has been performed. Owing to these two situations, an orthodontist would like to see that patient as frequently as possible. That would be after 3 months. In mixed dentition, generally the orthodontist, he would want to see the patient as frequently, at least for 6 months. But if there is a debilitated dentition like this, restorative procedures performed, and at the same time the primary molars and various stages of exfoliation, an orthodontist would want to see a bit more frequently. So now we come on to the 9th question. When a maxillary removable orthodontic appliance is placed, the effect on patient's speech will be what? We should understand, when a removable orthodontic appliance is placed in maxilla, the components of speech which would articulate in a fashion which would affect the maxilla would be affected. For example, the tongue, which is touching the anterior part of the palate, would be affected more frequently. Vowels are formed by open vocal cords, so it is more or less likely that vowels would be, or the linguloalveolar consonants, for several weeks they would be affected. It would be affected only for a few days. It has been found through studies of so many patients that patients are okay with the appliance, with speech, with the amount of salivation which increases with the first day of wearing the appliance, issue of the appliance. Such complaints, they decrease after 2 days to a few days more, maybe a week, but not more than a week. It cannot be a difficulty with linguloalveolar concerns for several weeks. Let us understand the word linguloalveolar. Linguloalveolar has two parts. Lingual, that is tongue. Alveolar is the anterior part of the maxilla, the alveolus, which has the removable plate, which will affect the consonants for a few days. Now, which of the following bone is used for the determination of growth pattern in the individual? Different skeletal maturity indices are there. Different ways of understanding the growth pattern in individual is there, whether the individual would grow a bit more, whether the mandible is going to grow till what age. We have to understand by looking at the skeletal age or the growth of the skeleton. Out of all these, most frequently cervical spine, that is cervical vertebrae maturity index, is used to predict the amount of the growth, especially for mandible. Why this question would be favorite for orthodontists is that the cervical spine has added advantage that can be seen in lateral cephalogram. So when we have lateral cephalogram, we can see the cervical spine, the cervical vertebrae. We can predict the growth of the patient. If the patient is a bit retrognathic, the mandible is posteriorly placed, and the patient is in growing stage, the growth spurt is still remaining. Like the vertebrae, they indicate that the growth spurt is still about to come. Then the treatment plan would change, because the mandible would grow by itself. You did not correct the retrognathism. Hence, cervical spine has added advantage which an orthodontist can use through lateral cephalogram only. There is no additional X-ray which is required. But other than cervical spine, there are other maturity indicators which are used, which is Henry's radiograph. The carpals, metacarpals and phalanges are used. Frontal sinus has also been postulated for indicating the skeletal maturity. Not frequently used. Dental radiographs are rarely used for indicating skeletal maturity. They are poor correlation. The correlation coefficient between the developmental status and the chronological age. Chronological age is the age from birth with respect to time, whereas the developmental status, that is the skeletal maturity, it has a correlation of 0.8, which is okay, not very good but not very bad, whereas the correlation of dental age with the chronological age is 0.7. Like using the dental radiographs or the clinical pictures of a patient, if you try to predict the chronological age in 10 patients, only in 7 patients you might find yourself to be true or towards true. But in 3 patients you will be wrong. Whereas if you try to use skeletal maturity indicators like cervical vertebrae, lateral cephalogram, Henry's radiographs, frontal sinus radiographs, dental radiographs, then you might get right in out of 10, 8 patients. So the correlation coefficient for skeletal maturity is 0.8, whereas for dental age it is 0.7. Yeah, there is one doubt which is raised in this question, is that which of the following bones are used for the determination of growth pattern in an individual? The doubt is very genuine, because growth pattern with respect to our dental profession is generally, especially with orthodontics, it is generally with respect to the vertical growth of the face or the horizontal growth of the face. But sometimes you have to try to understand what the examiner is thinking. It is the growth pattern is more as a general growth pattern. That is, whether the individual is going to grow rapidly, like there is a pubertal growth spurt, or whether the pubertal growth spurt has already happened, the skeletal maturity has already been achieved, and the growth pattern is now very slow, or it is not fast. Then if we look with that aspect, with what the examiner has put the question, like for determination of growth pattern with respect to the skeletal pattern, the answer C holds more true. But here we are not considering the vertical or the horizontal growth pattern. Mostly you have to visualize what the examiner is going to think. Like if we have a question from a particular chapter like clavicle, capitate, cervical spine and mandible, such options are with respect to one chapter. And if the answer is more relevant with respect to that chapter, then we should mark that. If we are going to think a lot about the question, then we might go wrong. Many a times second thoughts are frequently wrong. Now we come to the 11th question, which says that infant gum pad is divided into which of the following number of segments? Let us study the gum pads of infants. The alveolar process at the time of birth is called as gum pad. Now the gum pads, they are pink in color, form and covered by dense layer of fibrous periosteum. Now these gum pads, they are segmented into various units by grooves. The transverse groove for each gum pad divides for each developing tooth site. The transverse groove is for developing tooth site. The pads get divided into labiobuccal and lingual portion. The labiobuccal and the lingual portion by a dental groove. If it is for developing tooth site, it is transverse groove. If for labiobuccal and the lingual portion, it is dental groove. And there is also a groove for each quadrant between the canine and the first molar region and is called as lateral sulcus. Now this lateral sulcus is very important because it helps us to understand the interarch relationship at a very early age. That is, whether the patient, you can fairly predict whether the patient is class 2 or class 1 or class 3. Now these relation of gum pads, that is the maxillary gum pad and the mandibular gum pad, it shows certain characteristics. These gum pads, they show anterior open bite at rest and they contact only in the molar region. There is always a complete overjet. You see, at the same time, there is a class 2 pattern. Mandible is retrognathic in infants. The babies, when they are born, the mandible is retrognathic. And there is a reason why mandible is retrognathic. And the reason is that it helps for the passage of child through the birth canal. Mandible is distal to maxilla by 2.5 millimeter in males and 2.7 millimeter in males and 2.5 millimeter in females. So we come on to the next question. How much force should be applied to the condylar surface by the use of chin cup to stop mandibular growth in skeletal class 3 malocclusion? This is a question of application. It's a bit difficult, but then how it is? The condylar surface is approximately 200 square millimeter. Slightly difficult to remember. Now the condylar head dimension is 8 to 10 millimeter anterior-posteriorly and 15 to 20 mediolaterally. This is from a book called as Occasion. The magnitude of force recommended with a chin cup is 300 to 600 grams per side. So by calculating this square millimeter divided by 300 to 600 grams per side, we get force applied that would be 1.5 to 2 grams per square millimeter. That is 300 to 600 divided by 200. If you divide 300 by 200, it comes out to be 1.5. So 1.5, the option is 1.5 to 2 gram per square millimeter of the condylar surface. If there is a competitive exam where you have negative markings, you might want to leave this question because these numbers are a bit difficult to understand and remember. But of course, if it is a repeat question, you cannot make a mistake in this. If you make a mistake, you are backed by at least 200, 300 candidates. Repeat questions are really very important these days. Now we come on to the next question, which is 13th. Superimposition in cephalometric studies is done from registration point. This is best demonstrates the answer we might be knowing is that the growth farthest from the point. Now why a growth farthest from the point? Now I would like to give you one example for this. Imagine you are standing on earth and you want to know how the earth is moving. It's very difficult. For that you go to moon. Once you stand on the moon and view earth, you will be able to see earth rotating. But still you are not able to see the revolving earth. So if you go outside, outside to some other planet, then we will be able to see moon and earth both revolving around the sun. In the same way, if you want to study a point on mandible, like for example, point B, which is the intersection of anterior nasal, which is the intersection on the anterior border of the mandible between the alveolar process and the basal bone. So if this point B, growth and everything you want to understand, then if you are on chin, if you try to visualize from chin, B point will be growing very less. In fact, nil, because chin after puberty grows a lot more than point B. So you won't be able to visualize any growth in point B. But if you go towards cranium, which is already fully developed, you go to the base of the cranium, like on the SN plane, and then if you visualize, then you will see mandible as a whole along with the chin which is growing forwards, and hence if you go farthest from the structures, you go away from the muscles and other sutures which are involved in the growth, more better you will be able to understand the growth of that structure. Hence the registration points are generally farther away or at places where the growth has finished. We come on to the next question. Now there is a request to repeat the 12th question. How do we get to 1.5 to 2 grams per square millimeter of condylar surface? It is an application question. The condylar surface area is, imagine the condylar surface area. There is a surface area which is 200 grams square millimeter. Now the magnitude of force for chin cup is at least 300 grams per side. Per side we did not take into account because we have to consider only one condyle. So if you divide 300 grams of force by the square millimeter of condylar surface area available, we get 1.5 millimeter. So force applied would be at least 1.5 and the greater value will be 2, maximum 2, or maybe 3 if we go by 600 grams per side. I hope you have got the answer. So we move on to the next question, which is 14th. During smile, a pleasure curve is formed following the curve of anterior teeth, and some portion of the mesial surface of each tooth is visible. some portion of mesial surface of each tooth is visible. How much percentage of mesial surface of the teeth is visible during smiling or golden aesthetic rule? Now, according to the golden aesthetic rule, about 62% of adjacent tooth is visible. Like, for example, if the center incisor is seen fully, lateral incisor will be seen 62% of that, whereas canine would be seen 62% of lateral incisor. So the proportion of tooth visibility would go on decreasing as we go posteriorly. Center incisor seen fully, lateral incisor 62% of center incisor it will be seen, canine 62% of lateral incisor. So the question was, a pleasure curve is formed following the curve of anterior teeth and some portion of the mesial surface of each tooth is visible. Forget about the first half. Some portion of the mesial surface of each tooth is visible. How much percentage of the mesial surface is visible during smiling, which is also called as golden aesthetic rule? And the answer is 62 or closer to that, which is 60%. There is another question with respect to this. What is the minimum amount of incisor crown exposure required for good aesthetic smile? Minimum amount of incisor crown exposure, like how much the crown has to be visible when a patient is smiling. About 75%, if the incisor crown is visible, the smile is considered to be aesthetic. At the same time, if a patient is smiling a bit more, maybe up to 1 or 2 millimeter more than the incisal cervical part, that is on the gums, it is also considered to be normal. In orthodontics, you would consider intrusion of anteriors only if the exposure of the incisor is more than the whole incisor length plus 1 to 2 millimeter more. In fact, recently it has been said that a bit of gum visible in your smile is more youthful smile. But minimum would be at least 75%. Less than 75%, we would consider the incisal to be extruded. Also, it is important to remember that the vertical relationship of the lip to the incisors will change over time. That is, the vertical relationship of lip to the incisor would change over time, with the amount of incisor exposure decreasing with age. That means what? Are the incisors getting intruded? No, the incisors are not getting intruded, but the lips, they become less tonic. That is, the tone of the lips is lost. Hence, the youthful smile changes into the old smile as the time or the age advances. There is one more question with respect to microaesthetics, which is an additional question I would like to share. That is the zenith, the most apical part of gingival margin or the height of contour. Zenith is the most apical part of the height of contour. For lateral incisor, it is slightly lesser than canine and the center incisor, but in the middle of the tooth. If you see the lateral incisor, the arrow is exactly at the middle of the tooth, but slightly lower than the central incisor and the canine zenith. It is about 1 or 0.5 millimeter lesser than center incisor or canine. the zenith of central incisor is a bit distal, whereas for lateral incisor it is in the middle. Generally, the central incisor, as I told you, has the highest gingival level, but almost at the same level of canine. And the lateral incisor is 1.5 mm lower than the central incisor. If there is a difference of more than 2 mm, that is, the zenith of lateral incisor is lower than central incisor by more than 2 mm, a lay person can identify, which is very important, because orthodontic treatment depends more on what dentists visualize on lay persons than on dentists. We move on to the 15th question. Cephalometric analysis is used to evaluate growth changes by superimposition. Like how I told you, there are certain structures which are farther from the structures which we want to study, and they are already grown. So on these structures we superimpose. Like for example, in this picture you will be able to see, if you superimpose on the cranial base, that is from sella to nasion, if you are superimposing, or on the structures, you will be able to find how much the mandible has moved, how much the maxilla has moved, how much the teeth have moved with respect to the base of the cranium. Other superimpositions which are used are for maxillary and mandibular dentitions. On cranial based superimposition, you will be able to see how much the maxilla and mandibular have moved. But if you want to determine how much teeth have moved, you cannot use the cranial based superimposition, because when we want to understand the amount of movement of teeth, there is a confounding factor, which is the movement of maxilla itself also. We have to remove the movement of maxilla, then only we can find out how much the teeth have moved by themselves. So for that we superimpose on the maxilla, that is on the palatal plane. When you superimpose in the maxilla, we can say the teeth, they have, the red line is post, they have come ahead, and the upper teeth which have come behind, which is seen generally in the extraction cases. There is slight anchorage loss, at the same time there is retraction of the incisors. But this can be only seen on superimposition on the maxillary bone or the palatal plane, anterior nasal spine to posterior nasal spine. For mandibular dentition, frequently used is on the internal structures of the mandible, because the internal structures of mandible, for example, the inferior alunar now is very well demonstrated. Hence, we can directly superimpose on the internal structure and then find out the treatment progress. The red line is again the post, whether the molars have drifted ahead, whether the incisors have stayed at their own position, or they are drifted behind. So we come on to the question again. Cephalometric analysis is used to evaluate growth changes by superimposing on sella-nasion plane. Now we come on to the 16th question, which says that if the diameter of wire of a palatal canine retractor is doubled, the strength increases by. Important in this is not palatal canine retractor. Important is the wire. We have different formulas with respect to this. If you double the diameter of the wire, there are three main changes which are going to take place. One is with respect to the strength of the wire itself. If you double the diameter, that is, you make the wire thicker, of course the strength is going to increase. So it is going to become 8 times according to the formula. The strength becomes 8 times. the springiness, or in a layman language we can also call it as the resiliency. The springiness of the wire, it decreases by a factor of 16. Of course, the springiness would decrease if you increase the diameter, make the wire more thicker, then the springiness is going to decrease, but it would decrease by a factor of 16. At the same time, the range, that is the wire able to sustain elastic deformation before plastic deformation, the range will decrease by a factor of 2. Doubling the diameter, strength increases by 8 times, springiness decreases by a factor of 16, and range decreases by a factor of 2. So in this question, the answer would be the strength increases by 8 times. Now we move on to the next question, which is 17th. Moderate crowding is considered when space loss is. This is actually a factual based question. So whatever the text says, we have to write. Moderate crowding according to the text is 2 to 5 millimeter. But I would try to help you find out formulate a concept on this. Generally, the width of the premolar, that is in extraction case, the width of the premolar is 7 millimeter. So if you want to consider a severe crowding case where you remove full 7 millimeter and you want to retract all the whole 7 millimeter, then it becomes a high anchorage case. You do not want the anchorage loss, you want to utilize the 7 millimeter. So that means that crowding is severe. It is a high anchorage case. So from 5 to 7 it is severe crowding. But if you want the molars to drift ahead and not retract so much, then you would consider a bit of anchorage loss. When anchorage loss comes up, at least 2 millimeter of anchorage loss takes place, and from 5 to 2, that is, it becomes moderate crowding case. Till 2.5 millimeter of crowding, it is considered as mild, because you can do stripping, you do not have to extract. There is one more question in the same paper, that if there is a crowding of 2.5 millimeter, what you would like to consider proximal stripping, or proximal stripping is considered in crowding till what? 0 to 2.5. Now we come on to 18th question, which says that center of resistance is based on all of the following, except it depends on all except for the tooth position. Whatever the position of the tooth may be, the center of resistance would not change. Center of resistance is where the resistance to movement is supposed to be concentrated when a force is applied. It of course would depend on the size and the shape of the crown and the root. If the size and shape changes, this place where the center resistance is there would also change. As there is an attachment loss, the center of resistance, that is in cases of recession or loss of alveolar bone, the center of resistance goes to inferior position, that is towards apical position. So by elimination we have tooth position as the answer. Next we come on to the 19th question. Cephalometric point at the center of ramus of the mandible. It is a constructed point considered as the geometric center of the ramus of the mandible, which is a xi point. It is frequently used in superimposition of mandible, which will help us to find out the movement of the mandibular dentition. Now we come on to the 20th question, which says that if the mandibular first permanent molar erupts ectopically without much resorption of primary second molar, then the treatment of choice is see, in the previous question we had teeth in different stages of exfoliation. Now here the permanent molar has already erupted ectopically. The first permanent molar has already erupted ectopically. But there is no resorption of primary second molar, which indicates that it is not actually impinging on the primary second molar, that you would want to upright it. Then the treatment of choice is. Answer is disking of distal surface of primary second molar. See, the tooth has erupted. Now if you want to move the tooth in some direction, like the mesial direction behind the second molar, you have to slightly disc the primary second molar, which would help us to position the tooth just behind the primary second molar into right occlusion. But imagine if the tooth has not erupted and it is impinging onto the root of primary second molar, then you would consider use of brass wire to move permanent molar distally, or putting an attachment by raising a flap on the impacted tooth and uprighting it with some uprighting spring. Extraction of primary second molar is out of question, because if we extract, there will be lot of drifting into the space of second permanent molar. Now we come on to the 21st question. The supervision of a child's occlusion is most critical at the age of, like how I told you before, during mixed dentition stage, there is transition of primary dentition into permanent dentition. Different teeth are undergoing exfoliation, some teeth are erupting. Sequence, if disturbed or disrupted, might lead to increase in chances of malocclusion. At the same time, it is during this age when the growth spurts are very active. So it is very critical for an orthodontist to supervise child's occlusion between 7 to 10 years, that is during mixed dentition period. Next we come on to